Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei podcast. It is my great pleasure to introduce Dr. David Kandzari, who is the director of the Piedmont Heart Institute, chief scientific officer of the same institution, a very well-established interventionalist, complex interventionalist, and trialist involved in many areas of contemporary research, and a good friend for many, many years. So David, thank you so much for taking the time today to discuss with me about your career, how you became the one you became, and your advice for the generation that is coming next.
Manos, thank you. I'm privileged to be part of the Sensei podcast, and I'd always rather be talking about you or someone else than myself. But I'm privileged to share my story at least too.
Wonderful. So, David, well, maybe start from the beginning. I know you studied at Duke, but did you always want to become a doctor? How did this all come for you?
I did. I always wanted to be a physician, and in part that stems from my father, who's 86 years young and is a urologist, an academic urologist, and still practicing medicine today at his university. He was an academic urologist. My mother was a nurse in public health nursing, and the two of them together in our household led us to having magazines that were healthcare magazines or medical journals rather than Better Homes and Garden or Sports Illustrated on the coffee table. And I think in many ways, I just, and you know, our friends, we grew up in this town university environment, and I always had this ambition to become a doctor. I specifically, though, wanted to become a cardiac surgeon. And specifically as a kid, I even had pictures of hearts on my bedroom walls, and I had an appendectomy at age 9. And through that experience, I would then, afterward, during my recovery at home, I would operate on my stuffed animals. And my pajamas were scrubs from my father, and we had the cloth hats and masks back in the day. And I had this teddy bear named Henry, who's undergone multiple surgical procedures, and Henry was my patient. And really, it stemmed from a very young age that I wanted to be in medicine. It was just that when I was at Duke University and I was entering into what was termed then the Decade with Dave, it was a 10-year surgical cardiothoracic surgery residency with Dr. David Sabiston. I had an experience through the Sarnoff Endowment, which was during medical school a research opportunity, and they mandated that you work at another institution than your home institution. And so I had left Duke to work with Dr. Pascal Goldschmidt, who later went on to other great fame as an administrator and as a cardiovascular researcher. But I worked in Pascal Goldschmidt's lab at Johns Hopkins, and there I learned a great deal more about interventional cardiology and cardiovascular medicine. And it was such, and still today, as you've been part of, such a rapidly evolving subspecialty of medicine, and it was so engaging and attractive to me that I thought, wow, you know, I always want to be a proceduralist, but maybe this interventional cardiology aspect is something different that I should pursue instead of surgery. And I went back to Duke later and elected then to go the path of medicine, internal medicine, and then cardiology and interventional cardiology. And really, Manos, if I didn't do interventional cardiology, I don't know what I would have been doing in medicine. And I mean, I was very, very focused on just doing interventional cardiology. And probably for yourself too, when you and I were applying for fellowship, you might recall that we had to apply exclusively for interventional fellowship at the time of applying for the fellowship program. In other words, they would say to you in the program, at least, Manus, do you still want to come to this university even if we don't take you as an interventionalist? And you had to make a decision right at the time, and in front of this group. And sometimes you'd have to say, no, I really exclusively want to be an interventionalist and I'm not going to come otherwise. Now, today, people go into general cardiology and then they evolve and subspecialize and then later kind of select their subspecialty of EP, intervention, structural, et cetera. But back in my day, in our day, perhaps, you had to declare up front that you wanted to be an interventional cardiologist. So it was a fairly competitive program at the time, as it is still today.
Well, I guess it's a loss for the cardiac surgery department, it's a win for the interventional. So it worked out well in the long run. But actually, I was like you. Actually, I wanted to become a surgeon, and the reason I didn't is, the training path. I had to do a PhD. I mean, it was just like an extra 5 years, and I figured, you know what, that's maybe a little too much for me. So it's interesting how things evolve over the time. And obviously, we both did the right choice since
Yeah.
given the volume of procedures, the way it's going. So it worked out well in the long run.
No, you're
But
absolutely
how
right.
about the how about the complex stuff? So doing PCI is one thing, but then you've been extremely successful at complex PCI, cityo PCI, and now the innervation is now on the horizon. Other things as well. So what prompted you to get into that area and get excellent skills in something fairly complex and challenging?
The interest initially for me in complex intervention stemmed from my fellowship time, and specifically a very unique opportunity for me, even as a cardiology fellow, to work with Dr. John Simpson, who is a very storied, famed innovator in cardiovascular medicine, from atherectomy to over-the-wire technology to perclose to atherectomy, peripheral atherectomy technology, CTO technologies, and much and many others. And John had approached faculty at Duke looking for a fellow in interventional cardiology, and because John said, "Look, I really want somebody who's young and ambitious, not somebody who's at the senior part of his or her career, to work with me on these technologies." And so at the time, John was developing an atherectomy technology termed, Fox Hollow, which has later been acquired by now Medtronic and is used for peripheral procedures. But at the time, it was really intended for coronary use. And similarly, he was developing a technology that you might recall, men, is called the Lumen Frontrunner catheter as well, which was this device that kind of spread the tissue apart to dissect through coronary and peripheral total occlusions. And because of that experience, I traveled with Greg Robertson, who's still a friend and colleague at Emory University, and at the time, many of the famed leaders in complex intervention from the United States perspective, Jeff Hartzler, Pat Whitlow, among others, and we literally traveled the world performing cases in complex coronary intervention, whether it's atherectomy and bifurcation disease, or chronic total occlusions in South America, in Asia, in Europe. And I was doing all of this as a fellow. And so it was a really remarkable experience. And when I came on to faculty then and transitioned out of fellowship to faculty at Duke, my experience only continued. But Duke was, in many ways, a very storied and academic center for interventional cardiology. But it was also fairly conservative with regard to complex PCI. When we saw left main disease or chronic total occlusions, I think back at how many chronic total occlusions in symptomatic patients we saw where the perception was, oh, they've had that for 7 years. That's not new. They don't need it, or it's not cardiac pain. Or when we saw left main disease, we would send them automatically to surgery. And so it was really, on the one hand, a unique opportunity for me to venture out into something that others weren't doing at the program. And on the other hand, it was a bit of a balancing act to with senior faculty who might be more skeptical of me taking on these chronic total occlusions or more complex left main and or multi-vessel disease cases. And I think in part, having the experience with traveling the world and seeing how people were doing things elsewhere, it's been, for me, just a remarkable reward and privilege to go around the world and to see and be part of cases to say that, I always say for every 10 cases I see or see someone do something different, 9 out of those 10 times I might say, I wouldn't do it that way," or you could do it that way, but maybe I wouldn't do it exactly that way. But there's 1 out of 10 times when I see, I see somebody, one of our colleagues, I see someone worldwide do something different that I've never seen before. And really that's when we work in a field that you never stop learning and you never become complacent because there's always opportunity to do something different as well.
So you had your early days in Duke, but then obviously you moved to different places, and
Yeah.
that's been a very interesting career path. So if you're going to share with us, I know you've been through industry, been through Piedmont now. So how did that happen, and how that influenced your practice and everything else that you do?
No, thank you for asking. The very brief story for me was I was at Duke as a young faculty member, and within 1 week, and I still today believe completely by serendipity, I had received 2 phone calls from the leadership of the Cordis Corporation and Medtronic Cardiovascular asking me if I was interested in a role as their chief medical officer. And I was fairly young at the time, in my 30s, and there were people like Don Bain, who's so statured in interventional cardiology as the Boston Scientific chief medical officer, and I was honored to be thought of for the roles like that, but I respectfully declined. I just didn't think that that was something I was ready to do. And then things evolve, and I thought, If these companies are willing to take a risk on me, maybe I can contribute and maybe I can help." And so I left Duke, but what many people don't recognize is that when I left Duke full time to join Johnson and Johnson as a chief medical officer, I also did it under the conditions that I could still maintain my appointment at Duke University. Now, in today's environment, keep in mind this was the mid 2000s, and so in today's environment, that would be very challenging to do with conflicts of interest and regulations. But at the time, the faculty at Duke and the university were permissive of that, and the intent was that I really wasn't ready to give up still being a doctor. And it turns out that the role was so busy for me. I recall that in the first year alone, for American Airlines alone, I flew 637,000 miles. And that was not even on Continental, which I flew a lot too. So I was all over the world every week. And that's very exciting, but it's very fatiguing, but it's also it was taking me also away from something I still wasn't ready to give up, and that's being able to take care of patients. And after about a year and a half's time of doing that, I elected to leave Cordis under very positive terms with everyone, but I just still wasn't able to be a doctor. And so I'm someone who, in a unique way, has had the stethoscope taken from me, so to speak. And I never take it for granted then that, as us as interventionalists, when we're in clinic one day and we're thinking, oh, I got 30 patients in clinic or something, and I'm not ready to do that, do this whole day of clinic. I'd rather be in the cath lab. I'm still very much appreciative of those opportunities. And so what happened then too is I had for many years up to that point had gone to FDA and worked with the agency on a number of clinical trials and device technologies. And when the FDA had found out that maybe I was going to be transitioning, they approached me about the opportunity of becoming a medical officer for the FDA. And it worked out perfectly because my at that time, my children were still in school in North Carolina, and there was a timeline before I was going to go back to the Scripps Clinic and work as an interventional cardiologist and a clinician investigator. And so I became a medical officer for the Food and Drug Administration, and still serve today as a circulatory devices panel member and advisor to the FDA. So it's been a very unique trifecta, being a clinician investigator, a regulator, and someone who has had a role in industry as an executive. And it's given me a unique perspective for patient care, and a unique perspective on our healthcare system as well.
And then how did this lead, after you got back into practice, into you getting into the cityo world and the complex world?
So, my interest, as shared, stemmed well before that, of course, in complex intervention, and then things really escalated a lot for me by going to the Scripps Clinic and working with colleagues who really had a passion for complex intervention as well. And I'll jump ahead that about 3 years later, when I came back to the East Coast and I came to Piedmont Healthcare, really that transition to Piedmont was also just another catalyst, another step above for me and my experience in my career, because I went to an institution that was a very high volume institution for the Southeast, but in addition, it had 4 interventional cardiologists, Nick Lembo and Dimitri Komproliotis and Anna Klinich and Harold Carlson, who are all very skilled interventionalists, but also had a great passion for chronic total occlusion revascularization. And it was, some people might say, "Oh, that's too many," or you were fighting over cases. And really, it was the exact opposite. We had we really defined, I think, for us, best practice sharing and our shared wisdom, and we shared skill sets, and we really recognized that we were better as a team than any individual. And we, as you know, we then pursued many educational programs, many clinical trials. My first experience, though, with clinical trials in chronic total occlusions dated well back to my earlier days at Duke. I recall I was in the faculty lounge at TCT, and I thought, none of the technologies that we use in chronic total occlusions, and back then it was fairly rudimentary guide wires compared to what we have now, of course, but balloons, stents, guide wires, nothing was approved formally for cityo revascularization. And this was well before I had even started my time with Johnson & Johnson, but I ran into the leadership of J&J and proposed a trial of a study that would lead to the FDA approval of the Cypher sirolimus stent for chronic total occlusions. And when I got an optimistic response from that impression, I ran to the faculty lounge and I saw Chris Buller. And Chris, has been a leader in chronic total occlusion trials and development of technologies, and now is an industry executive himself. And he and I designed the TSCA trial, a cross Cypher TSCA 4 trial, which led to the approval of the Cypher. And since then, I think I've been part of designing and leading trials in the CTO space for just about maybe all but maybe 1 or 2 CTO technologies, ranging from guide wires and microcatheters and balloons and stents and others. And then that's the research side of it, because really in the beginning, CTO was such a largely unstudied space until leaders like you have really taken us to another level in our understanding of outcomes and procedural outcomes too. But it started with that first trial with the Cypher stent, and then led to a partnership with the FDA in designing trials for many other technologies. And then aside from the research, it really expanded to education as well. And in that regard, not only hosting programs and sometimes proctoring in my former experience, I've also, of course, like with you, been and many others, been part of many educational scientific programs, both sponsored by societies like SCAI and in programs embedded in TCT and ACC and the American Heart Association and EuroPCR and really worldwide for that matter. And I think, for me, it's been such a rewarding experience because I was part of the leadership and the design for the first CTO summit. And you've taken over a leadership role in that today. And for the first several years, I was part of that. But the very first CTO summit we had was not at the Marriott Marquis Hotel in New York City. It wasn't. It was at a dilapidated theater at Lenox Hill Hospital, and the room was so small that only faculty could attend inside the meeting, and one industry representative, and everybody else had to wait outside in the hallway. And that was the first CTO summit, and it was the first experience that many of, if not all of us, had seen this application of this what Antonio Colombo described was the Brutus technique, and that was the STAR technique, the subintimal tracking and reentry. But it was a much less refined procedure back then with a big loop J-wire and just thrashing down this coronary artery, kind of, something what had been done in the peripheral vasculature. And we were watching this being done just in amazement in a coronary artery and having successful, at least distal recanalization, right? And so I remember that Patrick Sorois was in the audience, maybe in the third row. I can still see as if it was 5 minutes ago. And he said that he had not been so inspired since that experience from something like watching Andreas Grunzig do balloon angioplasty. I mean, it was really just remarkable. And then, retrograde procedures came about. And I think I did my first CTO retrograde procedure in 2006 with Masahiko Ochiai at Singapore Live. And, that was the beginning of something different as well. And so it's really been an evolution. And I think what's been remarkable to me is to look back on plenary lectures that I gave 15 or 20 years ago in the CTO space, and how nascent, how early they were in thinking about CTOs when we were talking about might CT angiography be a benefit? Might MRI help us with viability? Might we think about clinical outcomes or patient-reported health status, and compared with what we have today, and even and through that whole process too, the other rewarding features is to be with people like yourself and so many others in the CTO space, to have a community and a family. And the community now is so much bigger, right? The world is flat. When I started out, CTO revascularization was principally limited to the, as this podcast may suggest, to our Japanese colleagues, the senseis, right? The masters of CTO revascularization. And now the world is flat. There's shared experience everywhere, and there are expert operators truly all over the world who have advanced this field tremendously. So I would just share, in terms of being with people like yourself and others at meetings. I even remember, I think it was 2005 or 6, being at the Summer in Seattle meeting with that Mark Reisman and Bill Gray had hosted. And this young interventional cardiologist comes up to me, and he has a red tie with cars all over it, and he's so enthusiastic, and he's going to Japan, and he's going to learn CTOs. And I thought, okay, good luck on that. And he said, yeah, I'm from Bellingham, Washington. And so he wasn't from a large university or anything. And then he introduced his name as we were parting, and he was Bill Lombardi. And so look where that has evolved, and what a successful career Bill has had in this space too.
Well, it's amazing, listening to you. It's essentially the whole story of the field, right, from the early days, inception, and going forward. So obviously you had a tremendous impact on both the clinical and the research side. And actually, how were you able to marry the two? As you know, most people are either doing one, either they're doing cases, some other people are doing research, but there's very few people who can actually manage the two bring them together. So how were you able to do this in the midst of many other things? Syntax, you got done so many things at the same time as well.
I should probably be asking you the same question. And part of the answer is that I think we burn both ends of the candle and we work 24/7. I've always had a very supportive family to understand, the passion I have for travel, for research, for the work that I do. Look at you and I tonight. We're just coming out of the cath lab as well, and still performing several hundred PCI cases a year, and yet still having the passion for research as well. And I think that part of it for me has been maintaining engagement with the healthcare industry, with colleagues in the healthcare industry, to still stay at the sharpest edge of the leading edge with regard to innovation and technologies, but being able to walk the walk and not just talk the talk. It's one thing to be at the podium and talk about complex intervention, but I've always felt that if you don't do it yourself, there's some element that's missing of it. And I don't feel that, I've always felt in complex intervention that when people are talking about a special guide wire or catheter or whatever it may be, and whether it's deliverable or not, or whether it has efficacy or safety, if I'm not actually using it myself, I probably shouldn't be speaking about it. So that's been my personal perspective on it, at least. How about for you, though?
So David, well, I'm with you. I agree with you that it's a combination, and it's hard to talk about something if you don't do it. And plus, the research, the clinical research, depends, especially the cityo world, on understanding it. Right? You have a perforation, what it means.
Yeah.
So I think you're absolutely right. That doing it makes you much more effective in leveraging the research part of it. But at the same time, as you said, burning the candle on both sides will lead to no candle.
Yes.
So
Yeah.
how do you keep your candle still, working and lit despite all this very busy work? What do you do?
Well, it's a timely discussion, isn't it? Because now I've taken on another a role in the past 3 years as the chief of our Heart Institute, which is maybe the biggest or largest, one of the largest, certainly in the country, with well over 200 employed or aligned cardiovascular physicians covering 23 hospitals. And our system now, our healthcare system, is the largest employer above even Delta Airlines in the state of Georgia. And so I've also taken on these other roles as well that are not, by all means, not a distraction, but they are a time commitment and a responsibility that I find real purpose in. And so, and yet we're seeing many on these other roles as well, seeing professional fatigue. And there are times certainly where I find more challenge than ever to find the hours in the day, or the days in the week, or the weeks in the month, to really get everything done that I'm trying to accomplish. There was a I'm coming to the answer here, I think, in a moment for you, Menace, too, or at least the best answer I can provide. But I remember at Johnson & Johnson, there was a policy or a rule that was often quoted, that if you can delegate at least 80, if somebody could do something at least 80% as well as you, then you should delegate it. And I'm terrible at delegation in that regard, because I want people to do it better than I can do it, ideally, right? Or at least as well as you can. And so I think for me, I've learned a lot. I learned a lot more about leadership and delegation and sharing. And I'm somebody that I know from whether it's a Myers-Briggs test or others, that I'm someone who, I don't have to necessarily lead the project, or it doesn't have to be me at the forefront, but I certainly want to know what's going on. And as long as I have a team around me or colleagues around me that are sharing that, I always wanted to be in research, because I wanted to know the results of the trial that you're presenting at the podium, Manus. Even if I'm not the one presenting it, I just wanted to know the results ahead of time. That was kind of my spirit. And so it's that passion, I think, that keeps me going. It's the passion to try something new. You can always reinvent yourself in this space, right? From being a complex interventionalist who does CTOs to then left main disease or, some other element of complex intervention, hemodynamic support. You can be a researcher investigating anything from hemodynamic support to chronic total occlusions to left main disease to now renal denervation. And you can explore other professional career paths like administrative roles that I'm also part of now.
So, do you exercise? How do you keep fit?
I do. I do. I try to as much as possible. So, because of my hours and always not coinciding with the gyms that other than those that are open 24/7, I usually exercise at home with fitness equipment routinely. My wife and I, we adopted just recently two greyhounds from Ireland, and so they keep us pretty busy too. Now they're a little bit faster; they're 45 miles an hour when they want to run. But also I have two young adult children, 22 and 24, Will and Stokes, and they're both very accomplished athletes in their own regard. But one passion we have is also for mountaineering, and we've done mountaineering and ice climbing throughout many parts of Europe, Iceland, Denali, and Alaska, and elsewhere. And so we were intending on trying to summit the Matterhorn earlier this past summer, but we're snowed out, and we hope to reapproach that this coming summer as well. So those are always good motivators for me to keep in shape, to try to keep up with my kids. And the other hobby or passion I had was in I used to surf a lot. I just don't get to do that in Atlanta anymore. And then I transitioned to racing vehicles, and I raced motorcycles for a while, which after a couple crashes, I probably transitioned out of that appropriately to now four wheels instead.
Wonderful. So, you must like the adrenaline and the excitement, I guess, of those sports.
Many people say that, and that's an appropriate response. That I'm a thrill seeker, but it's really not about risk or thrill seeking for me whatsoever. And I know that may sound strange, but really instead, what's the attraction, the appeal of these activities, really has exclusively to do with activities that consume and require my complete focus and attention and with no distractions. And specifically, when you're ascending a mountain with crampons and an ice axe at high altitude, you don't really think like, I wonder how many cases I have on Monday, right? Or if you're driving down a racetrack at 160 miles an hour and there's a 90-degree turn, you don't think, I got that manuscript that I still haven't finished the abstract for, right? And even I'll say even with surfing is that sure you can sit on a board and think about things for as long as you want, but when the wave comes and you become completely committed. And so if for me it's these activities. So the converse is I personally have no special passion to jump out of an airplane or for me to fly airplanes or things like that. So it's really not about thrill seeking. It's really about activities that require all of my attention. And I think that's for me what I'm extremely passionate about for interventional cardiology, because probably much like yourself, when I go into the room and it's me with the patient, all things go out the window for everything else. It's not about, do I have to take the car into the shop tomorrow, or, what's going to be for dinner tonight, or the budget is due for the healthcare system tomorrow, or the CEO wants this today. Nothing else. It's just all about me and this other individual, or, the task at hand of taking care of the patient. And so I find incredible um, uh, solitude in cases like that, or in complex cases, or even in, you know, rare instances of complications. It's not stressful per se. It's really rather very calming for me instead. It's kind of the opposite of one might expect.
Exactly. And as you said, focus is key for all of these activities, including the clinical and non-clinical. And this is definitely one of the ways to do it. Do you have any favorite book or any favorite movie?
um, Gosh, book I'd have to give a bit of thought about. But you know, and it's not necessarily Topol's textbook of interventional cardiology, right? But
I would be worried.
yeah, in terms of movies, maybe I could just could more quickly answer that one. So I've always been passionate about the film Jaws. I saw it as a kid at the beach in the summertime, and never went into the water the rest of the week when I was at the beach. And so I think there's maybe that's some work for a psychiatrist to work on with me after that. But there's some history that I've seen that now, you know, for many decades thereafter. I also I also really like the film the film Ratatouille. With cooking too, and I just think it's a great story. And there's the food critic. His name is Ego, and he says, "Give me some perspective." And you know, they come out and they're creative with it. So there's a lot of films though that I probably can't list one, but probably give you a 10. I do like watching films a lot.
And how many hours do you sleep every night?
Um, Certainly not enough, probably. But generally, for me, maybe 5 or so hours each evening. But for me, what I found too is that I really need specifically 2 a.m. to 6 a.m. East Coast time to sleep. Those 4 hours. And it's not that I stay up to 2 a.m. every night. By all means, no. But rather, when I'm in Europe, for instance, and we're at EuroPCR, for instance, 8 a.m. to 12 a.m., which is my 2 to 6 a.m., I'm completely worthless. And then once 12 noon hits, I'm back into, you know, back at it and seemingly awake and alert again. But I just need, there's something about my biologic rhythm that I need that 2 a.m. to 6 a.m.
Wonderful. And again, as you say, you clearly fight burnout much better than most people. So all these tips and tricks are very useful. Now, David, you've done so many things on the clinical work, on the research side, on the administrative side. Um, you know, each one of them is obviously tremendous. But what are the things that for you have been the most rewarding, the things you are most proud of?
Thank you. Gosh, it's hard to say because there are different things at different events in my career at different levels. Excuse me, that are so rewarding for me. For example, when I first was finishing fellowship, and I received the Tom Linnemeyer Award for the Young Interventionalist Award at TCT. At that time, I couldn't imagine any greater recognition, I think, in my young interventional career. And I have to say that was especially meaningful for me too, because I think the only recipient of that award who ever knew Tom Linnemeyer, and what a wonderful and generous person that he was, and a pioneer in interventional cardiology. So at that time, that's something that I was especially proud of, and I've been especially proud of being a leader in many programs, from the ACC I2 Summit to the SCAI Scientific Program, to a principal investigator of now, I think, more than 60 trials in the interventional space. But um, two more recent things that I'm especially proud of. One is not something that happened overnight, but in the past 13 years that I've been here at Piedmont Heart Institute, has been the evolution of this program to become I think, an internationally recognized center for complex treatment of complex cardiovascular disease for research. We're more academic than most universities, I often say, and we've in the past 12 to 13 years, we've averaged authorship in the New England Journal of Medicine every year, much less the Lancet and other groundbreaking trials. And so that's been especially rewarding for me, because I think when the founders of the Heart Institute put this program together, they never, very much perhaps like Minneapolis Heart Institute, they never imagined what a powerhouse the program would be from a research and innovation perspective as well. And our most recent accomplishment that's come out of this has been the recent approval of renal denervation therapy, which, as an adjunct to lifestyle interventions and medications, has the opportunity to impact hundreds of thousands of, well, truly millions of lives globally.
Absolutely. And again, phenomenal work. And I think everyone's excited about it. It took a long time to be approved. So I think there's a lot of excitement for these clinical applications. So David, what is the thing that is most exciting for you going forward? I think you've done it all. Is there anything else left to do?
There's probably several other things, and they're just elements that of our profession that I haven't had the ingenuity to discover, because a younger generation and senior and other other interventionalists are discovering. I think this field of interventional heart failure is really an exciting space in interventional cardiology that we haven't fully by all means, we haven't fully explored or tapped into. And I think we're just really at the beginning phases of that aspect of it. I think also the opportunities, look at what we've seen in terms of treating very complex patients with hemodynamic support and achievements of completeness of revascularization. We're now starting to become a little bit more mature in that, but we've got newer technologies on the horizon that I think are going to make those procedures safer and simpler, perhaps as well. And yet there are some areas that we've been working at, chronic total occlusions, you and I and so many others, at clarifying the clinical benefit for patients with this technology that we still haven't gotten complete resolution to. So there's a bit of old, but a bit of new as well.
Wonderful. So, David, if you have to close it with some advice for young generation people who are starting their careers or in their fellowships, and they want to be successful in research, education, administration, all the topics that you've touched during your career, what would your top piece of advice be?
I think it would be to not be shy, not be bashful about approaching people that many of us in our early part of our career might have thought, I can't approach him or her and ask them for mentorship or for advice. I was somebody perhaps like yourself who wasn't hesitant to walk up to Marty Leon and say, can you help me or can you teach me about something? And, you might be surprised at the responses that you'll get from many people who will take the time to support you, to mentor you, to give you guidance in your career as well. I guess the other element of it too is that, as I shared, we can always reinvent ourselves, as I've mentioned earlier in this profession, and not necessarily to corner ourselves in just one aspect of, in this case, interventional cardiology, not to be just exclusively known as a CTO operator or as somebody focusing on atherectomy or something like that, but to really be broad-based and be dynamic in this space.
Wonderful. Well, David, thanks again so much. Again, it's been amazing. Your course over the many years, it's been a pleasure working with you, and looking forward to continuing to do so.
Thank you for being such a good friend too, and for having me as part of the Spanish. Thank you.
Thank you for listening to the Sensei podcast.